Hi everyone, so my name is George, I'm an EM consultant at St Mary's and I work with Barbara and Lucy, and I'm here to talk primarily about Droperidol for the treatment of acute behavioural disturbance in the ED. And Droperidol isn't a new drug, it's actually been around for quite a long time as an antipsychotic, and it was used in the UK for a while, but I'll talk a bit about why it stopped being used and how we've reintroduced it more recently. It is used quite extensively in the US and Australia, but not in all departments. And we've used it in our department since September 2020 and found it a useful drug for patients with acute behavioural disturbance. So these aren't just the patients requiring a small amount of sedation. This is for the patients who have the ABD as a medical emergency, which is basically patients with the acute delirium, severe agitation, aggression, autonomic disturbance. And this may be due to a sole psychiatric cause, but often also relates to drug-related presentations. Our most common drug causing this in our department is methamphetamine, and also the occasional medical cause, whether it's hypoglycemia or encephalitis, can occasionally present similarly, and sometimes head injury can masquerade as this as well. So it's not only the psychiatric presentations. And these presentations present obviously a danger to staff, but also the patient themselves in terms of injury. And sometimes sedation is going to be necessary. We found that ideally IM sedation is better to avoid the risk of needle stick injury that is still present with IM, but is slightly more risky with inserting IV access. And ideally what you want is a drug that's going to work quickly and help you get control of the situation for those cases where verbal de-escalation or offer of oral medications is just not possible or does not work. So nice guidelines for rapid tranquilization include lorazepam and haloperidol that are often used in departments across the country, and we previously used as first line. But the problem with lorazepam is it actually takes quite a long time to kick in, particularly intramuscular. And the peak effect is around 60 minutes. And these are patients that you really need to get rapid control of the situation. So ideally you want a drug that works more quickly and reliably. The other issue is the problem with respiratory depression from benzodiazepines that can be quite a significant side effect. And often these patients are in a hypermetabolic state, hyperventilating, and suddenly if you slow down their respiratory drive, you present a risk of potentially temporarily worsening the acidosis and also running into difficulties with someone who now is struggling to breathe. So Droperidol is an antipsychotic drug. It's a dopamine antagonist. It's structurally similar and sounds like haloperidol, but it works quite a bit quicker. So it is absorbed rapidly IM and IV, its peak concentration and peak effect is reached within 10 minutes. So it's preferable from that point of view to lorazepam. The other benefit is that the level of sedation is slightly more reliable. We found that some people are sedated quite deeply with lorazepam, other people might not have so much effect, but Droperidol seems to have a slightly more reliable effect. It's actually not licensed for acute behavioural disturbance in the UK, but is licensed as an antiemetic, but it has been included in the recent RChem guidelines that now include both ketamine and Droperidol as first-line medications for this indication, partly due to the rapid effect and potential control of the situation. I would say that it does work well for a lot of cases and probably to the moderate severe end, but if you need extremely quick control of the situation, then it doesn't always work in all patients. We found about 90% of cases it should get you control of the situation. So I'll talk about the alternative drug that I would use in the very severe situations when you need immediate control. There have been concerns about the risk of torsade and arrhythmias relating to Droperidol, and that was the reason it was withdrawn. But actually, there's really large case series now from both Australia and the US that show that actually QT doesn't seem to be prolonged by the drug, and there isn't a noticeable danger from the use of Droperidol for this complication. We've been using the dose of 10 milligrams repeated for another 10 milligrams if necessary after 15 minutes. And this is then similar to treatment regimens that are used in Australia. Sometimes 5 milligram dose is appropriate. We're not using this for elderly patients above 65. It is potentially indicated for those, although if that is the case, I would use 5 milligrams, and also for patients who are underweight, and keeping a maximum dose of 20 milligrams. Just going back to the previous concerns about cases of torsade, they were offering cases where patients were being delivered much higher doses. So this is keeping the doses at a lower level, where it still appears to fairly rapidly control the patient in terms of helping alleviate the acute behavioural disturbance. In terms of monitoring, we've basically kept, initially when we started introducing it, we started keeping all patients in resus as a precaution, but found that actually that isn't absolutely necessary. And because there's less respiratory depression compared to lorazepam, actually it's probably safer, and we certainly can keep patients out in majors after being administered. Those who had had additional sedative drugs, or who have a lot of alcohol on board, or becoming very drowsy, we do monitor them in resus and use nasal capnography, but it isn't absolutely necessary for all patients. And safe discharge, I think, for any sedation, as for procedural sedation advice, that you'd want basically patients walking, talking, eating and drinking with normal vital signs and a reasonable time since the drug. There are some side effects. So there is, because of the mechanism of the drug, the amino antagonist, there is a risk of extrapyramidal side effects. And we have had one case of dystonia that clearly is distressing, and the last thing you want to introduce to a patient in this case. The incidence is about 1 in 250. So rare, but it will happen. The case responded reasonably well to procyclidine and diazepam quite quickly, but it's something to bear in mind. And clearly, if patients have got Parkinson's or a condition like that, then you'd want to avoid it. There's a few cases of transient hypotension that seem to correct quite quickly with fluid resuscitation. We've not had or been aware of any cases where patients have been persistently hypotensive. And although there's less respiratory depression with droperidol, there is potentially a risk of respiratory depression, and this normally happens in the cases where patients have had other sedative drugs either taken by the patient or administered by us, either before or after the medication. And there is theoretically a risk of prolonged QT, but that does not seem to be the case in the quite large case series that have been collected in other countries. In terms of our cases, we found that within 15 minutes, almost 60% of patients were basically in a state where we felt we had control of the situation. They were more relaxed, and 90% within 1 hour. And our case series was quite a high number of illicit drug presentations, as I say, mainly methamphetamine and a few synthetic cannabinoids. And the psychiatric presentations were more psychosis and mania. And this is a suspected cause. So clearly there's some overlap between the drug, alcohol, and the psychiatric presentations, where patients will often have one or two of the others. And there were some cases where it turned out that the patient was not thought to have any psychiatric condition at all, and it was just violent behaviour with the police. Just to say that the other medication recommended in the RChem acute behavioural disturbance guidelines is ketamine, as this is administered intramuscularly. And I think the way I see it is, I think ketamine should be for the more severe cases, and droperidol for the slightly less severe cases of acute behavioural disturbance. It does work very well in terms of controlling the situation rapidly, even when administered IM. It's at a higher dose than with IV, so administered approximately 4 milligrams per kilogram, or somewhere between 3 and 5 milligrams per kilogram. And the important thing to say about this is you need to treat the patients as you would with any other case of procedural sedation when administering medications like ketamine, so they will need to be in resus. Interestingly, in case series and trials, they seem to find that the rate of intubation is quite high in some case series, particularly in the US, whereas in Australia they don't have very high rates of intubation being necessary. So it probably reflects with the way people manage these cases. But I think if you're administering it, you need to be prepared for them potentially to progress to intubation, and treat these as any procedural sedation case. Concerns about autonomic dysfunction relating to ketamine and patients getting more tachycardic or more agitated don't seem to be borne out, and it can get you rapid control. There are obviously other options and many other drugs, and midazolam can be used effectively. Olanzapine can also work quite quickly when administered parenterally. So these aren't the only two options. I just wanted to talk about droperidol because we found it to be quite an effective drug in terms of gaining rapid control of the situation without many side effects, and certainly avoiding the respiratory depression that I always found a concern with midazolam in particular. So just a summary to say that droperidol is a potential treatment option and now recommended in RChem guidelines for patients with acute behavioural disturbance. It's fast acting, causes less respiratory depression and works quickly when delivered IM. And an alternative drug, if you want really rapid control of the situation, is IM ketamine. Thank you. Happy to take any questions or if you put anything in the chat.
Thanks ever so much for that, George. I've just given you a little virtual round of applause there. Really helpful. I think what we're going to do now, if it's okay with everybody, feel free to pop some questions in the chat, but just bearing in mind that we've only got till midday and still a few more speakers to come. So I think we'll go for a quick, if we round back here at 5 to 11, where we will be hearing from Jackie from King's about the search policy and Sachin, and then I will briefly talk about the room. And then finally, Gina is going to talk us through her personal experience of doing the RChem self-harm audit. So if we all join back in 5 minutes time for a quick toilet refreshment break. And then any questions for George, pop into the chat. I know that George is not able to join us for the second part. And if there's any questions I can't answer, then I will get the answers to you via George. Is that okay with everybody? Good. Thank you very much.
Really agitated.
This meeting is being recorded.
Yes, so my preference, if you need fairly rapid control, would be to add in midazolam if you're wanting something, because it's faster acting than lorazepam. Yes, it can be given. It means the risk of respiratory depression is slightly higher now that you've administered a benzo in combination. And we have had, to be honest, we've probably had cases where it's been the other way around, where someone's administered lorazepam either pre-hospital or in hospital, and then droperidol has been added on top of it. And those patients do tend to have a little bit of respiratory depression, but we found that it's less than those who have just been administered a lot of benzodiazepines. And so it's probably similar to a haloperidol lorazepam combination. It's just that you can, if you're using droperidol and then midazolam, hopefully everything will work quicker.
Yeah, sounds good.